Hello, guys. Today, the topic is fractures in children's. Fractures in children's are different from those in the adults because of its anatomical and physiological difference between the child and the adult bone. What are the difference? Peculiarity of the pediatric bone and the fracture healing different from adult. First thing is growing skeleton. At each end of the long bones and usually one end of the short bone, cartilaginous growth plate, potential weak point in bone giving rise to different types of epiphyseal injury. One difference is growth skeleton, and another thing is thick periosteum in the children's. Thick periosteum which will make the faster bone healing difficult to manipulate after 10 to 12 days after fracture, sclerosis around the fracture site radiographically. And another thing, third thing factor is increased vascularity, faster inflammatory response, higher body temperature up to 40 degrees Celsius. And this is the radiological X-ray, plain X-ray of the lower limb and the hand showing the long bones have two growing points, short bones have one growing points. For example, femur bone, for example, metacarpals. And the healing capacity of the children is different from adult. Why? Because one of the reason is remodeling capacity. Remodeling capacity is high in children compared to the adult. So reduction accuracy is less important compared to the adult. Because of the remodeling capacity is low, obviously reduction capacity should be high. So this capacity of remodel the deformity is based on the Wolff law. Wolff law is nothing but a while giving a repetitive loading of the bone will causes adaptive response enabling the bone to better cope with these loads. And this orientation of phases after asymmetrical growth is called as Harter and Volkmann law. Remodeling can occur in the plane of the joint. It does not happen if there are angular and rotational deformity. Side to side lead to proper union if there is alignment in the plane of the joint. It is called as Bayonet's opposition. What are the types of fractures in children? Mainly four types. One is birth fractures and related injuries, epiphyseal injuries, and fracture of the shaft of the long bones in older children, and pathological fractures. Birth fractures. Coming to the birth fractures, there are three types of fractures may occur in a newborn. Fracture or epiphyseal separation sustained during the difficulty delivery, fracture shaft of humerus, most common femur, clavicle, and multiple fractures associated with the congenital fragility of the bones, osteogenesis imperfecta. This is some of the congenital deformities, and pseudoarthrosis of the tibia is also pathological deformity. And these are the three examples of birth fractures in children. And epiphyseal injuries. The most common questions which arises in dealing with the children fracture is the physis involved or not? Does it lead to growth disturbances or not? Is the length and alignment of the fracture acceptable or not? This should be questioned before dealing with the physeal injuries. And physeal injuries. Injuries to the epiphysis of the bone almost always involve the growth plate, but most physeal fractures do not involve the epiphysis. The most examples is distal end radius physis and the distal tibial physis are the most frequently injured physis. Usually, the growth plate repairs well and rapidly, and most physeal injuries heal within 3 weeks. Compared to the adult, it takes 6 weeks. So it is half of the healing capacity. That's why remodeling capacity is more because in the children's rather than the adult. The rapid healing provide a limited window for reduction of deformity, as late reduction greater than 1 week after early physeal healing causes physeal damage. Damage to the plate can occur either by crushing, vascular compromise of the physis, or bone growth bridging from the metaphysis to the bony portion of the epiphysis. The damage can result in progressive angular deformity, limbal discrepancies, and joint integrity. Anyway, if we why the physeal injuries are very important because of the only three complications. One is because of the neglected physeal injury, it will lead to deformity. Either it may be rotational deformity or angular deformity. And second thing is It will causes limited discrepancies in the progressive age, and it also causes joint incongruity if intra-articular involvement is there. And this is very important diagram showing the epiphysis, physeal, and metaphysis and diaphyseal region. And to easily understand, the bone ends is divided into epiphysis, metaphysis, and diaphysis. And the epiphysis is surrounded by articular cartilage, and and the physeal region is divided into five zones. One is reserve zone, proliferative zone, maturation zone, degenerative zone, zone of provisional calcification. And here, this pictorial representation is exclusively showing the physeal region. Mm, Germinal zone, which deals with the origin of the cells, and the originated cells which get enlarged or multiply in the proliferative zone. These multiplied cells will get enlarged hypertrophic zone, and then this hypertrophic zone which get calcified and form a enchondral ossification. So physes are prone to injury as they may be weaker than the surrounding bone in tension or shear forces. The hypertrophic layer of the physes is the weakest of the physes. And this slide which mainly deals with the what are the physeal blood supply and how it deal in the fractures. Daily and Harris classification. The two types of epiphyseal blood supply as defined by the Daly and Harris in this type A and type B. Type A, the blood supply is supplied entire surrounding the articular cartilage. Here, blood supply is supplied partial to the articular cartilage. So, in type A, when there is any metaphyseal injury, then a complete damage to the blood supply will take place. Whether it is in type B, during the metaphyseal injury, it will not hamper the blood supply of the articular cartilage. These are the Pfizer classification most commonly we are reading the topic on the classification of the Pfizer injuries. Salter and Harris classification of Pfizer injury. Type 1, type 2, type 3, type 4, type 5. Type 1, which deals with the fracture occurs in the Pfizer lesion. Type 2 deals with the fracture occurs in the Pfizer lesion along with the metaphyseal lesion. Fracture occurs through the Pfizer lesion and epiphyseal lesion and extended to the joint. Type 4, fracture involving the epiphysis, physis, metaphysis. And type 5 is compressive force. Type 1, fracture no growth disturbances as resting zone is with epiphysis, except type A epiphysis like proximal femoral epiphysis treated conservatively. Wherever the resting zone is not involved, growth disturbances will not occur. So in that we can treat conservatively. If resting zone is involved, growth disturbances will occur, then we have to treat surgically. Metaphyseal fragment is present on the compressive side, which is called as Thurston-Holland sign. This is very important sign. The periosteum remains the intact on the metaphyseal side of the fracture and provide stability once the fracture has been reduced. Again, growth disturbances is rare as resting layer is intact. Physis and epiphysis intra-articular involve physeal separation with fracture through the epiphysis into the joint. Therefore, these injuries are intra-articular, and if displaced, this require anatomic reduction. For this reason, type A, type 2, type 1, type 2, which can be treated conservatively, type 2, type 4, which will be treated surgically. Epiphysis and physis and metaphysis and intra-articular. As the fracture line crosses the resting layer and enters the joint, anatomic reduction is necessary to prevent the articular incongruity and osseous bridging across the physis. Type 5 Salter Harris fracture involve a compression or crushing injury to the physis. They are rare and are difficult, if not impossible, to diagnose acutely due to lack of diagnostic radiographic signs. These fractures are generally diagnosed only after growth disturbances is recognized. Different rules to follow during evaluation. One first rule when dealing with the pediatric facial injuries is first contralateral limb X-ray for comparison. We should always do along with affected limb. Contralateral limb is also contralateral X-ray should also done in order to compare it. Second thing, immobilization of the affected extremity of the slab. How will you diagnose? Repeated X-ray of later after 10 days reveals periosteal reaction. MRI is also effective. Orthography can use it to case of intra-articular fracture. Harris growth arrest line. What are these lines deal with? Normally, along with the facial growth plate, some parallel lines will be seen in the X-ray. This parallel lines is normal facial growth. It will indicate the normal facial growth. But if any abnormal line parallel lines, then there will be a some growth abnormality can be indicated. It can be seen in 6 to 12 weeks following the injury, seen in the multiple bones in case systemic involvement. And these are the X-rays showing the facial lines, Harris facial lines. Treatment of facial injury. One is treat as early as possible so that outcome will be good. Goal of the treatment to maintain the anatomical reduction without damaging the dermal layer, maintaining an acceptable reduction. Factors to be considered while assessing the reduction is age of the patient. One is site of the injury, growth potential left, time since injury. If the time since injury was more than 7 to 10 days, it is advisable to accept the deformity in type 1 and type 2 injuries rather than the injuries already damaged facial. Lateral corrective